Namaste all. Thank you, Deepak sir. Thanks for the opportunity. Thanks, Capri Institute, to give me an opportunity um, uh, to put forth few things about headache. The management of headache, especially by physios. A comprehensive management of headache is the need of the hour today. So thanks again, Deepak sir, for giving me this opportunity. Myself, Dr. Naveen KS. I am based in Bangalore. I am a consultant manipulative physiotherapist and a chronic pain management specialist. I extensively do a lot of work on headaches. We treat quite extensively all forms of headache. So let me share my experience with headache today. Let's start the session about headache. Yeah. Headache, head pain, cephalalgia, call it way you want, it haunts. Headache is a headache to have, headache to diagnose, and headache to treat in a lighter sense, isn't it? None are spared. Headache haunts everyone on this earth would experience at least once in lifetime the headache. And if you are married, then every day. From small child, a beautiful lady, to elderly, headache haunts everyone. Now, in this 21st century, one of the commonest problem seen in health industry is headache, causing substantial disability, pain, leading to depression and also frustration. This burdens the person financially, socially, spiritually, and emotionally too. The commonest types of headaches being some tension headache, tension type, cervicogenic, migraine type, with aura, without aura. And there has been numerous treatment approaches to manage headache. Commonest being medicines, physiotherapy, cognitive behavioral therapy, CBT, and of course yoga being sought after of late, of which European Federation of Neurological Societies have apparently concluded that non-drug management, physiotherapy and needling must be considered. And manual therapies are the therapeutic strategy, in fact, most requested by patients with tension type headache. Also to mention, a national study conducted in USA revealed that most individuals with headache sought alternative therapies and manual therapy as their first choice. ICHD, International Classification of Headache Disorders, in their third edition, have classified more than 150 different types of headaches with two main categories. So the primary and secondary, so it becomes an enigma itself to understand it and to treat it. Some of the classifications are primary headaches, secondary headaches, some neuralgias, other type, and some of the classifications by ICHD. Anyways, let's not get into much details of classifications, subtypes, incidence and prevalence for now. Question is, are all headaches diagnosed or in the lines of ICHD guidelines? Maybe, may not be. Whom to see is a big question. A person with headache should approach whom? A ENT surgeon, a neurologist, a physician, a ophthalmologist, psychiatrist, orthopedician, neurosurgeon, dentist. List goes on even to Ayurveda, homeopathy, naturopathy, Rashtrapati, then why not a physio? If a patient walks into your department or clinic with headache, how many of us treat? We say, it is not my headache, it is not my headache. See a neurologist, isn't it? This is what we say. We should realize that headache is our cup of tea also, physios. Even if it is purely mechanical headache, we wrongly most of the time cross refer for chemical management. Though it is a mechanical headache, we send it for chemical management. It often happens. So, physiotherapist versus headache. Do we commonly see a person saying, I've got headache, let me see a physio? That should happen. How many of us are confident to treat headache? The contention here, my contention here, is a physiotherapist also should be a primary assessor and caregiver, a primary contact for all headache sufferers. We don't consider headache as our domain, isn't it? Please underline my contention here is a physio should be a primary contact when it comes to headache management. We are first when it comes to pain management. Why not headache? Is my contention. Headache is known to have primary or secondary cause. Known to have primary or secondary. Also known to have primary or secondary manifestations. It is imperative to treat both clinical manifestations. So, if primary cause happens to be mechanical, it has to be myofascial or articular dysfunction. Then physio's intervention can substantially reduce the pain, treat the chronic headache forever, in fact. Okay, let's not limit ourselves up to the neck, you see, when it comes to pain management. Let's rise above the neck to treat head also. What's called as head pain. If secondary myofascial or articular involvement is found, then our intervention can give, if not fully, partial solace or pain reduction to an extent, which itself will be a boon for subject suffering from chronic headache lasting for many years. Our management in such cases can be parallel to medical management, as it happens in rheumatoid arthritis, where both mechanical and chemical intervention happen parallelly. And if it is purely mechanical headache, and that's our job, absolutely. So whether it's acute or chronic headache, we can definitely alleviate pain. A physio has a major role in headache management actually, contrary to what was thought. It is a new dimension of intervention a physio can quite comprehensively offer. Either treat the source or symptomatically treat, isn't it? Whether acute or chronic headache, we definitely can treat the symptoms or even the cause, root cause. So, trigger point is our cup of tea, we all know. So, 54.6% of headaches and neck pain are caused by trigger points in a study. So, trigger points can come because of, the migraine headache can cause trigger points around the suboccipital and the upper cervical area, or on the scalp, or on the galea aponeurotica. Whiplash injury can give a lot of trigger points. A tension headache can give a lot of trigger points. Temporal arteritis or cluster headaches or cervicogenic headaches all can present themselves with some symptoms of trigger points, or they can show some trigger points. So, we all as physios, it's our cup of tea treating trigger point, and we love treating trigger points, isn't it? Today, that has become our practice base, and we all are actually big fans of Travel and Simmons, isn't it? So, some of the muscles and its referred pain and their trigger points and the location can vary, like the masseter showing referred pain through the jaw, and the suboccipitalis and splenius capitis and semispinalis to the back of the neck, and temporalis and frontalis to the head, sternocleidomastoid in fact to the front of the neck, and it can shoot up also many a times. SCM is very important, and scalenes also many a times gives shooting pain, and many scalene pain presents as if it's a TMJ or a shoots up and the patient says there is headache. and mid trapezius pain can go up to the mid back, and upper trapezius pain can go up to the shoulder. So these are some of the variations, and subject experiencing headache may have pain around ear, occipital area, scalp, neck, and around the eye. Mind you, very very important area. They have pain around the eye. Trigger points in muscles may have referred pain, as I mentioned. So a chronic pain or a headache, chronic headache, may lead to emotional disturbances too. So stress may predispose or further worsen the symptoms, and sleep deprivation also can contribute to headache. So some of the muscles which are very very important to be assessed, and as well as they may have trigger points are shown in the picture. Of course, scalene is missed there. Scalene is also scalenes are very very important muscles which can trigger headache. The clinical myofascial and articular manifestations of headache may reflect in the scalp, as I said, and superior nuchal line, supranucleal line, or suboccipital area and suboccipital muscles, especially OCI, obliquus capitis inferior, is a very very important muscle which actually contributes to headache. Then upper trapezius, vertical fibers, horizontal fibers, the splenius diagonally running muscle, splenius capitis, or sternocleidomastoid, as I mentioned earlier, scalene. I have to have mention especially the corrugator supercilii. I have a paper, I'll show you later. I'll mention corrugator supercilii later. The masseter, the temporalis, the occipitalis, the galea aponeurotica, as I mentioned, the Tmj, temporomandibular dysfunction can give a lot of headache triggering. Then of course the C2 vertebra, C2 dysfunction, C1, C2 dysfunction, or especially C2 malpositioned positional fault can also cause headache. Many times we fix the C2, headache is gone. All the above structures, as I am showing in the picture, can cause dysfunction and trigger points. Of course, to treat them is very very important. To assess them is very important. So what can happen? Most of the headaches have either primary or secondary involvement of myofascia. That is for sure, including that of scalp, face, articulations, where our expertise as physios lie. Taking advantage of the biomechanical assessment that we are capable of and we are good at, and interventional skills that we possess as physios, have a huge role to play in headache management. A misaligned vertebra irritating the spinal nerves, causing cervical muscle spasm, further irritating the nerves, leading to spasmodic episodes between pain and tightness in muscles and around the occiput. It's a vicious cycle of headache, and mostly in a tension type headache also. So there are symptoms from headache, related trigger points. There are some common symptoms that we see, and there are strange symptoms that we encounter in our practice. Some common symptoms, as we all know, deep ache, band-like pressure, sharp pain, throbbing pain, etc. are of course there. But there are strange symptoms to headache, that some trigger points that cause these strange symptoms, like toothache. A person may mistake it as a toothache, and many have got it extracted also. Toothache has led to subject to a dentist and the tooth been extracted. But the cause, the pain never goes, and then the cause been found, it's something else later. So headache has resulted in unnecessary tooth extraction. And tinnitus, headache can be causing tinnitus, or the trigger points, mechanical manifestations around can cause tinnitus, and they have sought ENT surgeons' help. And we have seen patients with headache and hard of hearing. So because of the headache, they had problem with hearing, and they have been after my intervention or physio's intervention, or after we have managed the mechanical part of it as physios, we have seen that the hearing has improved. For our surprise and disbelief, the hearing has improved many a times. And recently we had a patient with headache with blurred vision and some ear symptoms and ipsilateral vision also. But after we managed the headache, the vision improved. To our surprise, the vision improved, then the hearing improved. So here it is. So we have beautiful management in physiotherapy. So we have seen a lot of cases like these, where we have also seen TMJ pain and toothache disappearing along with headache when we interfere, when we treat the mechanical side of it. So what to infer with all this? That we as physios have to be, in the forefront treating headache. Okay, so assessment is the key now. Assessment is very, very important. We have to identify the biomechanical fault, the structures which are involved, and then the appropriate intervention. But the key also is the red flags. Red flags have to be identified, and what to treat, and more importantly, what not to treat is very important here. So the red flags, mnemonic is SNOOP, SSNOOPPPP. So is the standard SNOOP protocol to rule out the red flag. And we see the systemic symptoms like fever, chills, weight loss, the secondary risk factors like HIV or cancer or head and neck trauma can be. Some neurological signs have to be picked up, like confusion, loss of consciousness, some focal findings. Then onset, sudden, abrupt, the thunderclap, progressive over a long period of, or even older subjects greater than 50 years, you will have to be a little bit careful what is causing them headache. And sometimes get a CRP ESR possibly to rule out any inflammatory, and positional, many a times worse when they lie down and when they are hypertensive, or if there is a CSF leak, and something provoked like aura, any aura, some extra sound, loud sound, or the large light can actually trigger a migraine headache. And papilledema, ophthalmic, and any previous history with increasing frequency, severity, and significant changes in headache also, you should be little careful. So red flags, one thing that you'll have to watch out for. Then key structures to quickly screen. There are some structures which quickly needs to be screened for trigger points, some muscles which I already mentioned. Anyway, I will show you in the practical demo now. The Tmj dysfunction has to be assessed for TMJ has to be assessed for dysfunction, and if there is any TMJ related pain causing headache, has to be treated. TMJ can be treated. We physios treat very well the TMJ. We also mobilize the TMJ. The related muscles trigger point at masseter or lateral pterygoid or the medial pterygoid. So we treat TMJ related muscles also for trigger points and the TMJ for dysfunction, isn't it? Then the C2 dysfunction or C2 tenderness. First thing to check is the C2 tenderness. If there is any, then adequate intervention is required. Then the appropriate intervention. So key structures to quickly screen. I will show a demo, a little small practicals, how to screen. So to a quick assessment, to quickly screen for headache. So headache assessment, a quick assessment. As soon as the patient comes in, as soon as they enter itself, you have assessment going on in your mind. As physios, biomechanical assessment subconsciously starts, and we start observing their stood posture, kyphotic thorax, or rounded shoulder, poking chin. All that we would have already observed subconsciously. That is our inborn thing as physios. And once the patient has come and said they have a headache and have given chief complaints, and you have noted down, you have documented. Now the assessment part, to quickly screen, or as I said, the rounded shoulder. I am observing whether there is rounded shoulder, whether it should be sitting here. Then the poking chin and the carrying angle. Carrying angle and the poking chin, both I observe, and then see what angle it is deviated, and then correct it later. Then the muscles to be screened quickly are for trigger points are the trapezius, upper trapezius horizontal fibers, upper trapezius vertical fibers. So I check for trigger point. Then with the opposite hand, thumb, I check whether there is any trigger point in the vertical fibers of upper trapezius, and then quickly move my fingers little and laterally to see whether there are any trigger points on scalenes, the anterior, mid and the posterior scalenes, and then I move little more anteriorly to hold on to SCM. That's the sternocleidomastoid. I check for trigger points there, and then move little up to the mastoid process to see whether there is any trigger point at its attachment, and then slowly I move along the supranucleal line or the suboccipital line just to see whether there is any trigger point around there, especially where splenius capitis attaches or vertical fibers of upper trapezius attaches. So I have quickly screened for this, and then the mastoid process. And of course, I go in front and then check in front of the tragus on temporomandibular joint whether there is any trigger point or any dysfunction of the temporomandibular joint. I place my digit there, and then may ask the patient to open the mouth and close the mouth, and then feel for the click and the tenderness, and from front assessment I see whether there is any deviation of the mouth when opening. So that is temporomandibular joint assessment. Then also I check for masseter trigger point, so which influences the TMJ, and of course medial pterygoid, and mainly the temporalis muscle, which is also a key contributing muscle for headache, and then the corrugator supercilii. Corrugator supercilii, the frowning muscle, also check for its trigger point, whether there is any trigger point. Then of course I run my digit, palpating or trying to find the trigger point over the galea aponeurotica, which connects from occipitalis to frontalis. Then also over the scalp above the ear for trigger points. Sometimes we find trigger points in this area which we can treat. Then of course not to forget the C2, the first spinous process that we can palpate in the cervical area is C2. So thumb over thumb, I go on that and palpate or slight pressure to see whether it is tender. If it is tender, then immediate measures, there only I can try to fix C2. Is some of the assessment for key structures, key trigger points that we'll have to do. So after the practicals now, how to, what to, and when to choose what is very important question, intent question that we have to ask ourselves. A physio has a major role in headache management, contrary to what was thought. So we can offer quite comprehensively all the treatment, and we physio have beautiful weapons to treat, from lot of manual therapy techniques, invasive needling techniques, exercises, postural correction, trigger point therapy, soft tissue, deep tissue manipulation, all that. And in this picture, if you can see that those hands, if somebody can recognize that hand, that's the healing hand, and a very special hand, a legendary hands in physiotherapy, that is Deepak sir's hands. So I got his photo there just to as a this thing, Mulligan or the manual therapy techniques. So I call this weapons of headache destruction. Physios have weapons of headache destruction. Interventions as physios, manual therapy today find its place on top of the treatment chart, from silencing a trigger point to aligning articulations to motor control, to mention few trigger point to mention few of the manual therapy that trigger point release, whether it is digital or instrument assisted or soft tissue release or deep tissue manipulation or active release, PNF techniques, integrated neuromuscular inhibition technique, INIT, or Mulligan's, joint glides, etc. Dry needling, of course, with research evidences going for and against, has shown to be extremely beneficial in our practice. So practice based or clinically based evidences are for needling. So when trigger points are stubborn or adamant, dry needling can be handy. Therapeutic exercises has been our bread and butter, and of course is also the key in headache management. So posture correction is very important, has high influence on headache management, and electrotherapy has been favorite and continues to be favorite and basic physio tool to many. So that also adds as a complementary treatment strategy, electrotherapy. So usually on the first sitting, generally a manual therapy is advised, we suggested. So we do a manual therapy. All kinds of manual therapy can be chosen. You can integrate the manual therapy what you want in that subject, tailor-made, and complementary electrotherapy can be given. And second sitting, usually I call after 3 days. We repeat manual therapy and see how the symptoms are now, and then repeat manual therapy, and if required, TMJ manipulation and mobilization, and of course Roccabado exercises. If TMD is detected, we teach, and the dry needling. So let me give a little small demo or practical side of dry needling, and I'll come back. Little bit about dry needling practicals. So the key trigger points we have identified which are causing headache, and the key trigger point has to be needled. Needling has been a physio's of late favorite tool, a little invasive technique that physio has ventured, but has a very good benefit when there is adamant or non-resolving trigger point for manual therapy. Then we go for needling. We get various types of needles. This is 100 mm in length. This is 75 mm in length, 60 mm in length. This is 50 mm in length, 40 mm in length, 25 mm in length, 13 mm length also we get. A smaller length needle is used mainly for subcutaneous muscles Like corrugator supercilii frontalis can be needled with 13 mm needle. So depending on the depth that needle has to go, the depth of the trigger point, the thickness of the muscle, the needle sizes vary. Firstly, a gloved hand, a well sanitized gloved hand. Keep a cotton again with the sanitizer in it, soap, and then we take the needle, the required size needle, and then you open it up, bend this down, and you expose the inner needle. Once exposed, that's the safety you've removed, and hold the needle at the junction of the guide tube and the needle. You hold it this way and go place it on the key trigger point. So we have identified the key trigger point on the trapezius horizontal fibers, upper trapezius horizontal fibers. All we have to do is place it on the key trigger point, tap it. As you tap it, in one hand, one action, place the guide tube between your fingers. It will stay there. If you want to reuse the needle, this will be useful. Then all you have to do is, at the junction of the needle and the handle, all you have to do is go ahead and needle the trigger point. You may get local twitch response, and then that will be the sign of the right point to needled. Sometimes you don't get LTRs, but it's okay. Then if you can twirl it and then do it, the fascia, if it is adhered, will also release them. So I am twirling it. So twirl the needle and then do it again, and then take it out. And then if you want to needle again, I am holding the junction again there. Put it inside the guide tube from backwards. Block here. Leave it to fall down. Then again retract it a little bit back. Hold it at the junction. The needle is ready to be reused. So let me show the suboccipital needling and identify the supranucleal line trigger point. Supposing I find a trigger point there, all I do is place my fingers just above and below the trigger point, place it on the trigger point, and then slightly tap, and then the guide tube goes between the fingers in one single hand, one single motion. Then you can needle this, you can twirl it and then take it out. So same way the corrugator supercilii muscle, also can be needled, and OCI, especially obliquus capitis inferior, can be needled and has very good benefit with needling. Thank you so much. Then once that's done, third sitting, after yet another 3 days, we do appropriate previous interventions like manual therapy or manual therapy exercises, and review the exercises, and we teach now the self-release techniques like digital pressure, digital pressure, or on a chair as you see in the picture, or the iron rod of the couch or the edge of the couch. So you lie down, chin tucked, and then you can roll over over the supranucleal area, so that you grind at the edge of the supranucleal area. And of course, deep neck flexors activation is very, very important. So we teach nodding exercises. Then the postural correction, as I said, chin tuck, rounded shoulder correction, upper cross syndrome correction. Then more importantly, the thoracic spine extension and curvature building exercise is very, very important. thoracic spine has to be in extension. Most of them going in for kyphotic posture. That leads to carrying angle, poking chin, and causing lot of stress on suboccipital area. So if the chin has to be tucked and carrying angle has to be reduced, the thoracic extension is the key. For any neck related, suboccipital related problems, it's always the thoracic extension, which is very, very important. So also neck stretching exercise, sustained neck and neck muscle stretching exercise, very, very important. Now, interestingly, there is a study on corrugator supercilii, the frowning muscle, the corrugator supercilii, where Gairan B et al. In 2000 did a study on correlation of corrugator supercilii muscle resection in migraine headache. So they did the study on 314 subjects and they cut corrugator supercilii to people who had migraine type of headache, and for their surprise they saw the headache improved. So they blamed the corrugator supercilii in a chronic migraine. So once they cut or the resected the corrugator supercilii, there was elimination of migraine headache. So that was a very good study that they did. So as physios, let's not think about the surgery of it. We have our own tools to silence the corrugator supercilii, or we can also needle it instead of resecting it. So needling on corrugator supercilii can help a lot. Also they have found OCI, obliquus capitis inferior needling substantially reduces headache. In my headache practice, I needle OCI and corrugator supercilii depending on whether they have trigger point, and we have found lot of improvement. So this is one interesting thing that we had. So thus physio's role in headache management is quite comprehensive and is a parallel intervention to medical management in some and sole intervention in some. So awareness is the urgent need. There is a need for increase in awareness among sufferers as well as other medical professionals on the potential of physio in managing headache. A physio should have a first contact practice to assess and treat or cross-refer a subject suffering with headache. What say? So we should have a first contact. Thank you folks. Feel free to contact me, Dr. Naveen, on my mobile number 9844037934. Thank you Deepak sir. Thank you Tanmay, who is the technical brain behind compiling and technicality of it in broadcasting. Thank you once again Dr. Deepak Kumar of Capri Institute. There's no words to express my gratitude to you. You're always on the encouraging side. You always are pro physio, a great professional legend of physio, and then you encourage everyone to come up. Thank you so much sir. Thank you everybody. Namaste.